The second most common blood investigation is basic metabolic panel, which contains 7 common electrolytes: sodium, potassium, chloride, carbon dioxide, BUN, creatinine, and glucose. Now moving on to sodium. What is the normal plasma sodium level? It is 136 to 145 milliequivalents per liter. Why should we order sodium investigation? Because it is associated with water balance in the body. It regulates the extracellular fluid volume. What is the quantity of sodium in normal diet? It is 5 to 10 grams. Ideally, sodium intake should be less than the potassium intake. But we should know the processed food is rich in sodium. Here are some of the foods which contains more potassium but less sodium. Banana, orange, apple, pineapple, almond, dates, beans, potato. These are the foods which contains more potassium. The tender coconut water is a very good source of potassium. Here are the few conditions which causes increased plasma sodium level, and they are Cushing's disease, when the patient receives prolonged steroid therapy, dehydration, transfusion of blood with stored one, hyperaldosteronism. What is the function of aldosterone? It increases the sodium absorption. When there is excessive salt intake. And some medications which causes hypernatremia and should be aware or ampicillin, tetracycline, anabolic steroids, oral contraceptives, loop diuretics, osmotic diuretics. And what are the conditions which results in hyponatremia? In case of severe vomiting, severe diarrhea, burns, Addison's disease, renal failure, cardiac failure, hyperglycemia, and ketoacidosis. When there is excessive infusion of IV glucose, and the drugs which causes hyponatremia or ACE inhibitors, lithium, NSAIDs, vasopressin and oxytocin, chlorpropamide. The next most common electrolyte is potassium. The normal potassium level is 3.5 to 5 milliequivalents per liter. And why do we order potassium? To monitor the intracellular osmotic pressure. The conditions which causes hypokalemia or renal failure, conditions causing lysis of cells like hemolysis, rhabdomyolysis, crush injury, tissue necrosis, burns, tumor lysis after chemotherapy. What happens? So potassium is main content of intracellular space. When there is lysis of cells, the potassium moves from the intracellular to extracellular space. And here are the medications which causes hyperkalemia: spironolactone, ACE inhibitors, beta blockers, cyclosporin, digoxin. And what are the causes of hypokalemia? When there is increased renal excretion, gastrointestinal loss during severe diarrhea, vomiting, and when there is low potassium intake in case of pyloric obstruction or malabsorption, and drugs which causes hypokalemia or insulin, salbutamide, osmotic diuretics, acetazolamide, and steroids. And when should the potassium level be checked? When the patient presents with any cardiac disease and before drug administration like diuretics, AC inhibitors, and NSAIDs. In case of diabetic ketoacidosis, and when the patient receives large volume of fluids, when there is severe fluid loss, and during renal impairment. Next electrolyte is chloride. What is the plasma chloride concentration? Is 96 to 106 milliequivalents per liter. Chloride concentration is normally more in CSF than any other body fluids. Conditions of hypochloremia in severe dehydration, diarrhea, Cushing's syndrome, and conditions with hypochloremia in case of severe vomiting, excessive sweating, Addison's disease. When we talk about chloride channel, we should remember a genetic condition called cystic fibrosis. What happens in this is there is a point mutation in the gene CFTR, and the CFTR stands for cystic fibrosis transmembrane conductance receptor gene. So when there is mutation in this particular gene, it results in defective transport of chloride. So this causes thick protection of mucus due to loss of fluids. So in lungs and pancreas, there is excessive protection of thick mucus, which causes progressive damage and infection. The next one is carbon dioxide. Carbon dioxide blood test is also called bicarbonate test. And why is this test necessary? This is to check the pH balance. When the patient presents with shortness of breath, nausea, vomiting, and these might be the cause of lung dysfunction. The normal range of carbon dioxide is 23 to 29 milliequivalents per liter. And when there is low bicarbonate and low pH, that is metabolic acidosis. And what are the causes of metabolic acidosis? Renal failure, severe diarrhea, lactic acidosis, seizures, cancer, diabetic ketoacidosis. And when there is low bicarbonate but high pH, the condition is respiratory alkalosis. And the causes of respiratory alkalosis are hyperventilation, fever, pain, and during anxiety. So these are the two main conditions with low bicarbonate level. And here the bicarbonate level is high with low pH, and the condition is respiratory acidosis. The causes are mainly the lung disorders: pneumonia, COPD, asthma, pulmonary fibrosis, tuberculosis, lung carcinoma, pulmonary hypertension, and obesity. And here, when the bicarbonate level is high with high pH, the condition is metabolic alkalosis. And the causes are low potassium, chronic vomiting, and hypoventilation. The next component in basic electrolyte panel is BUN. BUN stands for blood urea nitrogen. The normal value of blood urea is 20 to 40 mg per dl. You should know urea is the end product of protein metabolism. The urea concentration increases as the age advances. So in younger individuals, the urea concentration would be the lower limit. Upper range in the older patients. The causes of increased BUN can be dealt under three headings: pre-renal, renal, and post-renal conditions. So what are the pre-renal conditions? Dehydration, diabetic coma, severe burns, fever in case of severe infections. And the renal conditions are glomerulonephritis, nephrosis, malignant hypertension, chronic pyelonephritis. The post-renal conditions are due to stones in the urinary tract, when there is enlarged prostate, and in case of bladder tumors. You should be aware of these medications when there is increased urea concentration: ACE inhibitors, acetaminophen, aminoglycosides, amphotericin B, diuretics, and NSAIDs. The next electrolyte is creatinine. So the normal serum creatinine level ranges from 0.7 to 1.4 mg per dl, and this is the sensitive indicator of renal function. Apart from kidney functions, this serum creatinine is important in the conditions like muscular dystrophies, where both the blood creatinine and urea creatinine is higher. And when the enzyme creatinine kinase is increased, it is the main indicator in myocardial infarction. And the last one under basic electrolyte panel is glucose. The normal fasting glucose level in non-diabetic individuals is 70 to 110 mg per dl. After a heavy carbohydrate meal, it can reach up to 140 to 150 mg per dl. So let's see about the glucose entry into the cells. So normally the glucose enters into the cell like adipocytes or muscle cell. It possesses a receptor called GLUT4, and glucose binds to this receptor from the extracellular space to intracellular. The GLUT4 functions under the influence of insulin. So what happens in diabetic patients? Due to deficiency of insulin, there is hindrance to the glucose entry into the cells, which causes increased serum glucose level. And just remember, whereas in the liver, the glucose entry into the cell is through GLUT2 receptor and not T4, and this receptor is not under the influence of insulin.